Okay, good morning, our dear professors and colleagues joining us from at least 10 countries now over the world. I am Ahmed Kouhi, lecturer of endemic medicine at Cairo University and coordinator of Qasr Al Aini HIV and viral hepatitis fighting group. And it's my pleasure to welcome you all to the United Conference of Hepatogastroenterology and Infectious Diseases 2020 on the COVID-19 Monothematic Conference under the title of the unique Egyptian experience between the experience and the evidence. Now it's my pleasure to introduce my dear professor, Professor Amgad Al-Dhahabi, Professor of Hepatogastroenterology and Infectious Diseases at Al-Azhar University. Dr. Amgad, please, the floor is yours.
Thank you, Dr. Kordi. Good morning, everybody. It's a good day to welcome you all, the attendees, participants, Egyptian and non-Egyptian speakers and chairpersons belonging to 7 countries. I'd like to welcome you all for this scientific day about the current nightmare of the world, COVID-19. It affected 34 million worldwide with 1 million deaths. In the situation in Egypt, it affected more than 100,000 people and the mortality approaching 6,000. The program of today includes 1 plenary session with 6 parallel sessions and 2 industrial symposia that will cover all COVID aspects and updated knowledge. On behalf of the board of the United Conference of Hepatogastroenterology and Infectious Diseases, I'd like to thank the Egyptian Society of Fever and the World Gastroenterology Organization, all the universities and scientific organizations who are contributing to this great event. Many thanks for Eva Pharma and the Habib Scientific Office for sponsoring this meeting. And also, I would like to thank the ICOM company, the organizing company of this meeting. Good luck and have a good day. Now I'll leave the mic to the chairpersons and to start presenting. Let me speak first and welcome the chairpersons of this session, Professor Dr. Maysa Abdallah, Professor of Gastroenterology and Hepatology in Al-Zaqazig University, Professor Muhammad Ali Mukhlis, Professor at the National Research Institute, and Professor Rabab Fouad, who is a Professor of Hepatogastroenterology and Infectious Disease in Qasr Al Aini University. I'll let the mic to the chairpersons to start presenting the speakers. So please, Dr. Maysa.
Good morning, everybody. I'm very happy to join all of you today. It's my pleasure to introduce Dr. Francois Winters, the Deputy and Executive Director of the WITS Reproductive Health and HIV Institute, University of Witwatersrand. Welcome, Dr. Francois. He will talk about COVID-19 in Africa, a completely different situation.
Thank you, everybody, and thank you for the introduction. Welcome from Johannesburg, where we've just had our first rains, but there's lightning, so if the power lines get struck, it might be why I disappear suddenly. Can you see my screen?
Yes.
Oh, that's wonderful. So I'm going to give you a very quick overview of this. I'm going to predominantly talk about Southern Africa because most of that data, unfortunately, is from South Africa. Because I think the epidemic, the COVID epidemic around Northern Africa, you guys know better than I do. But also because I think the demographics that people are concerned about in Southern Africa are very much linked to some of the sort of epidemiology I'm going to be chatting about now. Now, South Africa is unique in the sense it's got really good sentinel surveillance. We do lots of things very badly, but surveillance we do pretty well. And we also have possibly the largest concentration of PCR labs in the world, thanks to our HIV program, which is massive, and where viral loads are run through routinely on all the patients who are on there. So what about Southern Africa and most of Africa? Actually, what characterizes them? The first thing is that we have very severe health limitations. I think that South Africa is middle income, so we've got less than most, but other countries are severely limited. They also have severely limited PCR capabilities, which is obviously a major component of the COVID response. And it's important to understand this. One of the critiques of WHO is the focus on PCR testing in Africa, in a situation where for the last 17 or 18 years, we've been scaling up, and we know we're close to getting the kind of numbers for the HIV patients that we required, let alone the additional load that COVID would bring us. What's also characteristic, and I think it's similar to throughout the world, is we've got very overcrowded cities, very similar to Brazil, probably to Cairo, to big chunks of Asia. And where we differ from places like Europe, where people are in very dense areas, is the level of a concentration of people within one domicile. So you'll have often 6 or 7 people living in a place that normally would accommodate 1 or 2 people in Europe. So this overcrowding, obviously, for respiratory virus is profound. Also, we have very limited communication networks. Data is very expensive. So we many countries in Asia have used innovative apps, and Korea has used sort of cell phone triangulation for case finding of COVID. We do not have that here. In South Africa, the app has been rolled out recently, and we have yet to see any data from it to see whether it's working or not, what the uptake is. So it is a respiratory virus. I think increasingly it's clear that surface spread is not anywhere close to being a significant transmission area. And the symptoms are largely respiratory and gastrointestinal. Now, the reason I'm raising this, the fact that it's respiratory spread and that the symptoms are respiratory and gastrointestinal, is this. This is a very famous photograph from Time magazine, actually, of an area just outside Cape Town, possibly one of the richest areas in Africa. On the right, you can see some of the most upmarket housing that you could possibly want. There's this marshland between, and on the left is a fairly conventional informal settlement. Now, in that informal settlement, people have routine respiratory and gastrointestinal symptoms, as you'd expect from a very, very densely overcrowded area. That means that it's very difficult for us to use these as a means to differentiate testing programs. This, I suspect, you can find in Rio. I suspect you've got it in Cairo. I suspect it's in huge chunks across the world in middle-income countries, where you have this disparity between rich and poor, but where poor people live in a very densely congregated area. But Africa is also very varied. These are just photographs from my own country. On the extreme left at the bottom is where I work, which is in urban central Johannesburg, very overcrowded. On the coastline, though, physical distancing is almost the norm. You don't need to worry about it. While up at the top right is an informal settlement between Johannesburg and Pretoria, with the high-tech, super-fast train travels past these informal settlements. So what do we have to guide us anticipating what's going to happen on the continent? Now, there's a lot of concern this is data from the US, demonstrating that being black is an issue, seems to confer some sort of mortality, firstly of getting the virus, but also of dying of the virus. But unfortunately, race is so confounded with a whole of poverty issues, such as being insured or uninsured. You can see here, being uninsured in the US is also associated with poor outcomes. And on the right there, as you'd expect, people who are slightly more crowded, where there's more than one person per room, are more likely to get it. Again, not good news for the African continent. Even if the race stuff is confounded, the overcrowding and the poverty that's demonstrated here is an issue. So when we were talking about what was coming with the first discussions in March, there were lots of people who were very, very optimistic in the absence of data that, the whole of things that are going to save Africa. And I'll talk about each one as it comes along, because it's a useful way to frame some of the thinking as the epidemiology is still evolving. So the first thing was that lack of transport networks across the continent, not just air travel into the continent, but also trains across borders, bus routes, and all the usual road travel that goes in. And certainly there is far less air travel in Africa. My sister's a pilot. She keeps sending me these maps of planes at any one point over the areas of the globe. And I'm always struck at how few planes are over Africa relative to Asia, Europe, and even South America, compared to us. Now, obviously, where you guys are, there's a lot more air travel. Particularly Turkey is such a major hub, and Cairo itself is not a small hub. But certainly in Africa, there's only 2 or 3 major hubs, predominantly around Kenya, Nigeria, and South Africa. So perhaps we wouldn't be seeded as quickly. And certainly that is what happened. We think that the seeding process particularly from Italy and from China, the original seeding probably was compromised there. But because also across border and between urban and rural areas was more constrained, highly infectious virus was stopped from transmitting as we think. So the other thing, as I said, race was put forward, that Black people, maybe they get less virus than anybody else. Now, all the data that we've had, and this is even more data from the US, does not suggest that. If anything, it suggests that being Black, and particularly if you're Hispanic, and certainly in the British cohorts, being Indian extraction was actually a risk factor for other outcomes. Now, the problem again is that race is so caught up in socioeconomic issues, and also areas around issues as diverse as cultural issues such as diet, that you see, for instance, diabetes is different in these communities, which is a risk factor for severe COVID. Then there was this idea that tenofovir would save us. And there's some basic science data to suggest that tenofovir, which is component of first-line therapy in probably 97% of all patients in the world, and certainly in the same percentage in Africa, that perhaps people with HIV who might be prone to getting severe COVID would be protected from it as almost as a sort of pre-exposure prophylaxis and post-exposure prophylaxis, because tenofovir was part of their regimen. Now, with COVID-19, we really initially only had case reports around HIV. Now, a huge proportion, particularly in my area, in the southern tip, HIV is possibly the commonest chronic disease. In fact, it is the commonest chronic disease. But initially, the reports that came out of Spain, out of New York, there were just these case series around what HIV confers in terms of risk. As you know, these are other risk factors, which I'll be coming back to again and again. But often people with HIV tend to be younger. They tend not to have as many comorbidities. And the idea is, do people with HIV have a different disease course? Is it because they've got immune dysfunction? This COVID's an immune disease. Are they protected against some of those immunological consequences, or do they get it worse? This data then was published from Cape Town from an amazing group of collaborators there just 3 or 4 weeks ago, and it's freely available if you want to go and pull it down, and looked at 4,000 HIV positive patients with COVID in that group. And as my co-author on the commentary said, it's 40 times more than all the published case series combined. So this is a massive case series, and pretty much has reassured us that, in fact, there is a small risk to being HIV positive in terms of mortality. There does appear to be a situation where people on tenofovir do seem to have slight protection against mortality, but it's very small. And when I say small, it's the same risk associated with being male and having poor COVID outcomes. So when this came out, it was actually very reassuring. It doesn't appear that HIV by itself confers a major risk to COVID mortality. And this, I'm sorry, it doesn't project very well, but it, as I said, it's freely available in CID. You can just download it. The table is very clear. It showed that, and I'm sorry that I see the arrows haven't aligned well either, but it's again demonstrated that the risk factors in Cape Town were very similar to the rest of the world. It seemed like if you were male, if you were older, if you had diabetes, what was clear in this particular cohort, though, that was not characteristic of other cohorts, is that they were able to pull the HbA1cs of the diabetic patients and actually demonstrate that uncontrolled diabetes conferred significantly more risk to you than controlled diabetes. So diabetes by itself is a problem, but uncontrolled diabetes is even a bigger problem. So this was an incredible data set. Also demonstrated that TB, either previous TB or current TB, conferred a moderate risk to increasing your risk. But really it was age and diabetes that seemed to be characteristic. And you can see hypertension, some of the other classic risk factors for COVID mortality are there. However, the tenofovir thing is a little bit bedeviled by something else. It's actually not tenofovir. It's probably the introduction of dolutegravir. Many of you are familiar that the fact that dolutegravir has been recommended to by WHO and has been rolled out across the tens of millions of Africans. Now, you might ask, why is that? So we published this last year, and he's speaking later on this session, but demonstrated that actually people on dolutegravir seem to gain a lot of weight, particularly when it's combined with tenofovir alafenamide, which most of us don't have routine access to. But even on just conventional tenofovir dolutegravir 3TC, patients gain a significant amount of weight, particularly women. Now, that has been confirmed late last year, earlier this year, in a CID publication by Paul Sachs, looking at other integrase inhibitors like bictegravir, newer antiretrovirals, including rilpivirine, are associated with weight gain. And this paper, which actually came out a few hours ago, which was our 96-week data, which was published this morning in the Lancet HIV, demonstrates that this trajectory of weight gain is a pretty straight line. Much worse in women, which is not good news because the majority of patients on HIV treatment in Africa are women, but is a pretty straight line. So even though dolutegravir confers all these benefits, it's now it's going to make you fat. Obesity and hypertension is also strongly correlated with obesity. So we might be actually inadvertently making our patients very vulnerable to COVID consequences. And this is something that is worrying us because in South Africa, certainly we already have a pre-existing obesity epidemic. So what else could be correlated with better outcomes? And people have sort of said our climate will protect us. Now that's a stupid statement to my mind because what happens in Cairo is very different to what happens in central Nigeria, is very different to Rwanda, is very different to Lesotho. You can have deserts and you can have incredibly high temperatures, but Lesotho, it snows during winter routinely. So I don't quite understand this assertion that climate somehow would protect a whole continent that has a diversity that we have. It strikes me as a little bit offensive, actually. But there's been modeling exercises looking at climate change and demonstrating that even though there might be an impact in terms of coronavirus, it's likely to be very, very moderate. So there's been a lot of speculation about first waves and second waves, and I look forward to the discussion, particularly about what's happening in North Africa. But we don't know what's going to happen. Are you going to get a first wave and then a bigger second wave like we saw with pandemic flu in 2018? Are we just going to get at the bottom there a first very big wave and then a slow burn that comes afterwards? And that certainly is what we think, certainly in South Africa and our region, is what we've seen. Is we think we saw a massive initial wave, which I'll show you in a moment, and then the slow burn where we're getting continued cases at a much lower level, but still significant. So other things that came up is people said, oh, we'll be okay because we have very little diabetes and very little, and we've got a very young population. Now, that's true. Most African countries are significantly younger than Europe and America and Asia, but that's not the case across the board. South Africa, for instance, the average population is only 2 years younger than the general population, the global average age. So you have to be quite careful about this. In a place like Mozambique or Malawi, yes, the population is much younger, and we know that that's associated with less with better outcomes when it comes to COVID. This shows, for instance, in South Africa, TB. This shows our causes of death. As I said, we collect this kind of information pretty well, and you can see TB is our number one killer, but diabetes is our second biggest killer. So diabetes is very, very prevalent in our society. So this idea that comorbidities don't exist in Africa, again, is just homogenizing the whole region. I'm sure the same goes for the whole of North Africa, is that Egypt and places like this have got very different demographics from a place like Malawi. So I'm going to finish up by just talking about South Africa. It's a middle-income country. As I said, our HIV programs meant that we actually have some of the best PCR coverage in the world. It has not meant that we've done a very good job about our testing program. And if we've got time in the discussion, I'll talk about that. Part of it was just we didn't have access to the reagents. You can have the machines, but if you can't repurpose HIV viral loads to PCR because the reagents are not the same for COVID. We also have excellent pandemic experience. We've been dealing with HIV and TB forever. We've had listeria outbreaks. We have expertise with malaria, with cholera. We sent experts out to Ebola. So the country itself actually knew a lot about pandemics, and I'd imagine that Egypt as well. You guys have got Hep C. You've had other outbreaks and things in that area. We're not strangers to these things in Africa. In terms of South Africa, though, we were, until a few weeks ago, probably we've slipped down the scale, but we were number 5 globally in terms of new cases. So just after Brazil and Russia and the US, we came in. I'll show you a graph in a moment. That slipped down the way. Part of the reason for that, though, is because we were actually doing some testing. So we were identifying cases. It's not necessarily that we were number 5 globally. I find it quite difficult to believe. So in March, we had possibly one of the most harsh lockdowns in the world, where honestly, the streets of Johannesburg were completely empty. There was no one driving on the highway. The police and the army were on the streets. There was a massive impact on primary care. Nobody was able to get to their healthcare facilities. And the various provinces were hit at different waves. The Western Cape around Cape Town got it first. It then swept into adjacent province, the Eastern Cape, and then hit my province, Gauteng, a couple of weeks later. And with the usual health challenges I'll talk about in a moment. And it was interesting because we had a lot of high-profile politicians infected. When we watched the Brazilian president and Boris Johnson, we had the same. We had lots of our politicians hit. The lockdown's been steadily eased, and we've been able to kind of piece together what happened in South Africa since then. But here you can see the numbers. We still picking up the piece around deaths and around the numbers recovered, but you can see that South Africa, in August certainly was still doing pretty well. And as I said, the numbers have dwindled dramatically since August. So what actually happened? So it's important that we don't extrapolate the South African data to other countries without some concern, because we are a different country and we still haven't got all the data in front of us. But we think the community seeding happened in March, mainly from Italy, interestingly, and a little bit from, but because we shut down the entire society when the first 20 cases were in the country, we think it was delayed by a few weeks. But then we think it exploded. And despite the lockdown, it swept its way through the urban areas, infecting almost huge numbers of people. It was projected to be September last month, but in fact, it looks like it was June when it tore its way through. The health services were not overrun. We had access to steroids, which actually did help, and our physicians were quite good. And I'm quite proud of our doctors and nurses actually about what they did there. But by and large, other than in one of the rural provinces, we managed to hold things together. Yesterday we went over 16,000 deaths. A lot of deaths are not measured though. We do document excess mortality where some of the deaths that weren't documented are collected through the death certificate data, and we think it's probably close to 40,000. As I said, we'll only be able to piece this together going towards the end of the year and early next year. And we now have data, some serology from Cape Town and from Johannesburg, as well as from the vaccine studies, where in the vaccine study I'm participating in, 25% of the participants, completely asymptomatic, coming in for the vaccine, were PCR positive on screening for the vaccine study. And the serology suggests about 20 to 40% of the population was affected during that June-July period. And as I said, still going on, but we saw this massive surge during that period, earlier than we anticipated. However, and this is data showing the dramatic impact on the TB program. This is just gene experts. We have gene expert machines in every corner of the country. But for TB, for HIV, I can show you the same graphs for HIV, for vaccine coverage. It's been a massive blow to all those programs. People were too scared to go to the clinics. The police were arresting people for being on the streets for all sorts of reasons. People were just not coming in for care. And this is unfortunately the legacy we're going to be dealt post-COVID, is going to be picking up the pieces of these other programs. So now we're in the business of trying to predict what's coming. And there's lots of this. This is a really interesting article in the European Journal of Epidemiology, looking at Uganda, looking at South Africa, and looking at different forms of the intervention and how they might actually override the number of ICU beds. As I said, we didn't actually run out of beds at any point other than this one province. So this is a useful metric, but at the moment, nobody seems to know what's the second wave is going to look like. Is it going to look like it's what's happening in Europe at the moment? Is it just going to be these burns, these hotspots that develop as they are in Asia? So just to end off, now what is? So it's unclear if South Africa represents the rest of the continent. I think the best data is probably going to be from your region and from us for the moment. A lot of the countries implemented similar lockdowns. I think the South African one was the most severe that I can see. But the whole of Africa put in place restrictions in terms of air travel. In fact, some of the most rapid and restrictive ones, the borders were closed everywhere. So there's very limited testing. So again, I would be hesitant to look at the numbers. South Africa is the 5th biggest. I have no idea why Nigeria would be spared. And certainly we have very limited data coming out of there. But my instinct as an infectious diseases person is that it's probably going to look very similar in the urban areas. In South Africa, the rural areas have been completely spared. The numbers there are tiny compared to the urban areas. But there's no reassurance that we are going to do better. This idea is about climate and tenofovir and all the rest. It seems like age will have some protection, that it's a young continent, that perhaps people will be protected because of that. But it's speculative at this stage. I think the age thing is probably beyond speculation, but the rest of the stuff, I don't know. And I guess the question then is for all of us is, what will the next wave look like? What do we need to do to prepare the health system? How do we not have the economic devastation that the first lockdown wrought? How do we protect the primary healthcare services? And how do we just mitigate the damage at the same time being prepared for this next wave, which none of us knows what that looks like at the moment. And I know that your next talk is going to do but I think something we're going to have as a continent we're going to have to deal with is the rise of global nationalism around vaccines and other resources that we've seen. Is what happens if we at the back of the queue in terms of access to vaccines. And I'm looking really forward to the next talk, which, as I understand, is going to be discussing that. So thank you very much for the invitation, and I'm looking really forward to the rest of the session.
Thank you so much, Dr. Francois, for your really illustrative talk that we got from it, a very interesting information. Thank you so much.
Thank you.